All right, so for the ninth installment, we want to talk about arrhythmias. Now, we're not going to talk about specific arrhythmias. If you just finished listening to 8, don't worry, we're not jumping ahead. We're going to cover some things, and it's all going to kind of coalesce together so you can synthesize the information. Bear with me here. So an arrhythmia is anything different from what the heart should be doing. Any deviation from normality is an arrhythmia. So an absence of electrical activity would be an arrhythmia, would count. So what can cause an arrhythmia? What causes the heart to not do what it is supposed to do? If the heart's starving for oxygen, if part of the heart is dead, if part of the heart is infarcted and dying, that can cause an arrhythmia. Nervous system imbalances, neurotransmitter imbalances, chemical imbalances, distension of the chambers of the heart that have been beating too hard for too long, like with unmanaged high blood pressure, or people that live at very high elevations, they can do that. What are some other things? So blood gas abnormalities, when you don't have enough oxygen in your blood, if you're full of carbon monoxide, if you are full of electrolytes in the wrong balance, calcium, potassium, magnesium, chloride, sodium, all of these can have an impact to some degree or another in the heart if they are not in the proper ratio. Remember homeostasis, that's where the body wants to be, it's where it wants to function. There can also be trauma to the heart itself. Take a baseball, we'll use that example again, a line drive to the chest, or hit a steering wheel during a car accident. There are also drug effects. These include both illicit and street drugs, your vitamin supplements, and of course drugs that your doctor may have you on that maybe your body's metabolism slows down, it doesn't get rid of them properly, or you overdose, you forget and take too much, so on and so forth. And then of course electrocution. It makes sense that too much electricity would cause a problem in something that runs off of electricity. Other things are body temperature, okay? So hypothermia and hyperthermia can both have severe effects on the heart. If you have central nervous system damage, this can also cause a huge problem. And then there are, of course, the things we don't understand, or what we'll call idiopathic. Idio meaning unknown, pathic, you get it. So unknown events, unknown pathology events. And then there are normal occurrences. So there are people who are just born that way. There are also things like axis deviation in pregnancy. And it's okay if you don't know what axis deviation is yet. We'll cover that more in depth. But there are things that happen as a natural part of how we as human beings live and reproduce and so on and so forth that can make a difference in how our heart functions. Not every one of them means that there's a problem. Just bear that in mind. So how do we classify arrhythmias? How do we name them? Because the names become important. We name them in a couple of different ways. One of them is the nature of origin. So one is an example of digitalis toxicity, right? If you have certain types of cardiac drugs in your body, you can, in an over amount, in a larger amount than should be there, you can have digitalis toxicity. So this is one of those where we name it according to the nature of the origin. The other one can be named according to magnitude. So in the cases of left ventricular hypertrophy, which sort of bleeds over into another one, we see greater amounts of electrical discharge. So we say, okay, well, there must be a greater amount of electricity going through there, and thereby a greater amount of muscle for it to perfuse through. And then, of course, there's the site of origin. Left atrial enlargement is another one. We also name things according to severity, and nothing really great comes off the top of my head for that one. We also name them according to where they originate, so things that originate in the top of the heart. So we'll talk about the really good tachycardias. We call them supraventricular tachycardia. That's above the ventricles, so supraventricular tachycardia. And then we also name them according to where they come from. For example, tachycardia that originates in the ventricles would be ventricular tachycardia. You guys get the idea. We can also name them according to whether or not they originate in certain parts of the heart in terms of very specific places. So AV junction is one where if we say a first degree AV block, a second degree AV block type 1, second degree type 2, third degree AV block, so on and so forth. And then, of course, there's the disorders of conduction themselves that we'll kind of name out. So let's talk about some of them as they originate in the place that they originate from, or in the place from which they originate, I guess is how you say it. So some that originate in the SA nodes: sinus bradycardia, sinus tachycardia, sinus arrhythmia, sinus arrest, sinus block, sinus pause, sick sinus syndrome, which is a bit of a catch-all. So let's kind of discuss those individually. Sinus bradycardia can be caused by increased parasympathetic tone. It can be an intrinsic disease of the SA node itself. There can be a blocking of the right coronary artery, which causes a reduction in blood flow, which means that this SA node doesn't fire as quickly as it should. We can also get this from certain drugs like calcium channel blockers like cardizem or digitalis, or even amiodarone can cause sinus bradycardia. And it is also a normal finding in a very healthy and well-conditioned person. So if you have a marathon runner, it would not be uncommon for them to have sinus bradycardia. A fun fact I like to bring up is that at his peak physical condition, Lance Armstrong's resting heart rate was somewhere around 38. And there actually are slower heart rates than that recorded. The slowest heart rate, I forget what it is, but I actually did a video on it because I was kind of blown away. And if you want to look that up, it's in the Bet You Didn't Know series. So what does this mean? What does sinus bradycardia mean? Well, the first thing you need to look for is, are they bradycardic and symptomatic? So do they have bradycardia, and are they pale or diaphoretic, not perfusing well, passing out when they stand up, weak, unable to mentate? So when things like that happen, it's because of decreased cardiac output, and the heart is not able to put out the blood flow that it needs. It's not having the cardiac output that would sustain life and mentation and so on and so forth. You can see hypotension with this. You can see chest pain. You can see all kinds of other things. If there's signs of poor perfusion, you have to fix it. You have to determine how stable your patient is and fix it. So one of the ways we would do that might be with a medication called atropine. Usual dose of that is a 0.5 milligram up to 3 milligrams, and you can give a 0.5 milligram every 3 to 5 minutes up until you hit 3 milligrams. That doesn't mean you give 3 milligrams of atropine at one time. So you give 0.5 milligram every 3 to 5 minutes until you achieve a heart rate that is acceptable, which is above 60. And then you can repeat that essentially 6 times. If the patient is not stable, you wouldn't go with atropine. You would prepare for pacing. So you would pace this patient using electricity. So you would click the pacing button on your monitor. You would set your rate, which can be between 60 and 80, depending upon where you work and what they want you to do with it. And then you would dial up the milliamps until you achieved electrical capture. And that electrical capture would be a paced rhythm showing up on the EKG. And then you would palpate for a pulse, usually in the femoral artery, because the top of the body jumps. You would palpate for a pulse in the femoral artery, and you would dial up the milliamps until you achieved what's called mechanical capture, meaning you could feel a pulse when your pacer fires. And that is how generally we treat sinus bradycardia. Now, that is not every situation. That's just something in there for you to know. All right. And we'll move forward to sinus tachycardia. So sinus tachycardia is an increased rate of SA node discharge. It's sinus because it's coming from the sinuses. It's coming from the upper portion of the heart. And it can also be a normal finding if someone's running, if someone is exercising, if someone's very hot, if some, as in the case of fever or environmental problems. It can also be a reaction to fear. It can be a reaction to pain. There's a lot of things that can happen. It can also be a reaction to heart failure or to an MI. Different types of things, hypoxia. Someone could have a very active thyroid, an overactive thyroid, or have taken too much of their medication, such as Synthroid, and this would cause sinus tachycardia. So always look for the origin of sinus tachycardia. Sinus tachycardia within itself is not usually a terribly bad thing. It is a decent functioning heart because it is at least sinus tachycardia. Look for the underlying reason. Is it hypovolemia? Are they bleeding to death? So on and so forth. Fix that, and you usually fix the sinus tachycardia. All of your treatment in sinus tachycardia is going to be directed at the underlying cause. So another one, as we continue through the sinus portions here, is going to be the sinus arrhythmia. So what is a sinus arrhythmia? There's a problem where the SA node doesn't fire exactly as it should. It doesn't send out signals. Usually this manifests as a variation in the R to R interval. So there's usually a problem in the R to R. Now, what can happen, or when can this happen? If you're very young or very old, this can be a normal variant. It can be a heart that's not fully formed the way it should be, or it can be a heart that's not functioning the way it used to in the case of the very old, your 80-year-olds and 90-year-olds. It doesn't mean all your 80-year-old people have it. It just means that it can be there and it can be benign. It can be not that big of a thing. Moving forward into sinus arrest. So sinus arrest is when the heart fails to discharge for a brief period. So this is usually more than one QRS complex. That's what makes it a sinus arrest. So sinus pause is when one QRS complex is not there, when there's one entire P wave QRS complex and everything is not there in between beats. The sinus arrest is a little bit different. There's usually at least two there. It's just a standstill of the SA node. So what would cause that? Ischemia could cause it. Digitalis toxicity rears its ugly head again, and other drug toxicities as well. Excessive or increased vagal tone. A good place to see this would be in an intubated person who is becoming more and more conscious, or even if they're not, you can actually see increased vagal tone just because they have a tube in their throat and you're stimulating the vagus nerve. And then there's degenerative diseases that can actually cause it as well. And we're not going to go into each one of those because these lectures will be endless if that were the case. So we'll kind of go forward from here. There are going to be more sinus arrhythmias in your book, in your text, whatever text accompanies your course. However, we're not going to go into every one of those because the sinus arrhythmias are deep and they are different, and people tend to interpret rhythms differently. And for that reason, I don't want a big backlash on the internet of everyone thinking that either the channel is wrong or thinking that they're wrong, because there is so much differentiation in the sinus arrhythmias. The bottom line on this is most of your sinus arrhythmias, you're either going to treat the underlying cause or you're going to treat it not at all. And the only time you really have to treat any sinus arrhythmia is when it is due to something that is life-threatening, i.e. hypovolemia, or when the sinus arrhythmia itself is a threat to life, such as sinus bradycardia. And with that, we'll wrap up this block and move to the next one.